All right, I think we're live. So good afternoon, everybody on Facebook. This is our second installment this week about updates with regards to research from our annual ASCO meeting. Today we have Sara Robinson, who is a partner of mine who works up in the Longmont office. She has been pivotal in breast cancer research within the U.S. Oncology organization and in Rocky Mountain Cancer Center. She grew up in Texas, and did her medical school training in Houston, did residency at Baylor and the University of Colorado, and did her fellowship at Baylor in Dallas, Texas. She's been with Rocky Mountain Cancer Center for 6 years now. She's been focusing more on breast cancer and has been pivotal in developing a multidisciplinary approach to breast cancer care here in Longmont, Colorado. Today, she's going to be going through 2 clinical trials that there was a lot of discussion about at ASCO, one of which involves surgery, the other of which involves immunotherapy. So I will go ahead and transition over to Sara. And after we're done, we're going to have a little Q&A session at the end.
Hi, good afternoon, everybody. Thank you for the introduction, Hossein. It's good to be with everybody today. As he mentioned, we're going to go over a few highlights from ASCO 2020 as it pertains to breast cancer. So our overview today is to spend the majority of time on ECOG 210 trial, looking at the role of surgery in metastatic breast cancer. And then I'm going to talk about some additional highlights from 2 other trials, Keynote 355, and then additionally HER2 CLIMB. And I'll mention that all these data sets are focusing on questions in the metastatic setting. So ECOG 2108 is an age-old debate. This is finally a randomized phase 3 trial that was done without bias that shows whether or not there's value in early local therapy for an intact breast primary cancer with metastatic disease. So de novo metastatic breast cancer means that at the time of breast cancer presentation, there's evidence of stage 4 or incurable disease. This is present at diagnosis in about 5 to 6% of patients in the United States. And then we see higher percents in resource-constrained countries, up to 10 to 20%. So the rationale behind this study is that local regional treatment is hypothesized to improve survival based on retrospective analysis. So here's the pros and the cons regarding this debate over time. The pros are that improved survival in numerous retrospective studies have been shown. The thought is that removing the breast primary eliminates the primary tumor as the source of new distant metastasis and reduces likelihood of uncontrolled local disease. Potentially also improves quality of life. On the con side is the argument that survival has improved for all metastatic breast cancer due to our excellent systemic control with newer therapies. And retrospective studies have been biased. So women receiving local therapy prior were younger, they had smaller tumors, and more of these tumors were hormone positive with lower disease burden. And finally, the thought is that this can produce excess toxicity and healthcare costs and potential delay in systemic therapy. So 2 randomized trials have been completed and published that tested the value of local regional therapy in stage 4 breast cancer with conflicting results. The first one was conducted in India in 2017, and the second through the Turkish Federation that was reported out in 2018. So you can see on the left, there was no observed survival advantage with early local regional therapy in the trial from India. The survival curves basically overlap, and the hazard ratio is close to 0. On the right side, the Turkish Federation trial, when analyzed at 5 years, did favor early local regional therapy with an overall survival benefit approaching 17%. But if you look more closely at this trial, this was really in younger women with bone-only disease. ECOG 2108 opened in 2011, and the last patients were enrolled in 2015. So ECOG recruited women with stage 4 de novo breast cancer, so metastatic disease at presentation with an intact breast primary. These patients received optimal systemic therapy based on patient disease features in accordance with concurrent guidelines. Those who did not progress at distant sites following 4 to 8 months of therapy were randomized to either continue systemic therapy alone or early local control with continuation of systemic therapy following this. All patients were followed for 5 years. The details of the early local therapy paralleled our current guidelines for treatment of women with non-metastatic breast cancer and included complete tumor resection with free surgical margins, post-operative radiotherapy per standard of care. So the types of patients that were enrolled are presented here. These are key population features. There were 390 that were registered, 256 that were randomized, median age of 57, and 70% were postmenopausal. These were mostly locally advanced breast cancers that were palpable and quite a large size with nodal involvement. Most were ER/PR positive and HER2 negative. Less than 10% were triple negative. As far as distant metastatic disease, mostly had single organ involvement. There were approximately 40% with bone-only disease and 25% that presented with visceral crisis. With regards to initial systemic therapy, chemotherapy with or without a HER2-directed agent was used in more than half of the participants. And otherwise, as I mentioned, local regional therapy was performed per standard of care. So this is really the most important slide, which shows the overall survival of the entire population for this trial. So you can see the survival curves overlap completely and are superimposable. So there's no hint of an advantage in terms of survival with the use of local regional therapy at the primary site. As you can see, which we'll look at an additional slide, there was, of course, as expected, less local regional recurrence addressing the breast primary. It is interesting to see a median survival of this trial of 54 months in metastatic breast cancer patients, whether they had local regional therapy or not. 5-year survival was roughly 40 to 45%, which really points towards our better systemic therapy as time goes on. Looking at overall survival by tumor subtype, triple negative cancers obviously did the worst. In fact, they did worse if their systemic therapy was stopped for a period of time for local control, which speaks to the aggressive nature of that disease. That is shown to the far left. With regard to HER2 positive and hormone receptor positive HER2 negative disease, the survivor curves are very similar to the main analysis. As far as local regional progression, you can see that 43 local regional recurrences were discovered in this trial. The top line in purple is the regional recurrences with systemic therapy alone, and then the local occurrences drop down to 10% with control of the primary disease. So it's about 2.5 times greater control, and this was statistically significant. Finally and briefly, despite local regional therapy improving local control, as we saw on the previous slide, it did not improve quality of life. At least it was not statistically significant based on a quality of life tool that measured patients' symptoms. Oops, sorry, I gotta go back. So what about oligometastatic disease, and what does that even mean? So there is a subset of de novo stage 4 presentation with an intact breast primary and less than or equal to 4 distant metastatic sites. So this is thought-provoking, but if you look back at the Turkish Federation trial that showed an improvement on survival with solitary bone mets, it raises the question, what should the management of de novo oligometastatic breast cancer be when we only have minimal sites of disease? So there is an ongoing Japanese trial that is addressing this question, looking at systemic therapy with the addition of targeted therapy, whether it be stereotactic body radiation or resection of all metastasis. And if we can eliminate these sites, does it possible render these patients no evidence disease or long-term control? So in summary of ECOG 2108, existing data supports that local regional therapy does not improve survival. Local regional therapy does reduce subsequent local regional progression, about 2.5%, but does not improve quality of life. Up to 20% of patients treated with systemic therapy alone will need local regional therapy at some point for palliation or progression. Local regional therapy should be considered for patients that become symptomatic or progress locally. There could be a role for routine local regional therapy for de novo illegal metastatic breast cancer, again, meaning that there's less than or equal to 4 sites of metastatic disease in combination with systemic therapy plus ablative techniques of all metastasis to secure long-term no evidence of disease or cure, but this is a subject of ongoing clinical trials. Next, we'll move on to Keynote 355. This was a randomized double-blind phase 3 study of pembrolizumab plus chemotherapy versus placebo and chemotherapy for previously untreated, locally recurrent, inoperable, or metastatic triple-negative breast cancer. So what is immunotherapy? Basically, simply put, it's therapy that triggers the immune system. PD-L1 as a marker, what is that? So it's a protein that helps keep the immune system from attacking non-harmful cells in the body. In cancer cells, this can allow the tricking the immune system and not being recognized as foreign, and so the T cells are less likely to help with the response. So chemotherapy is a rationale in combination partner with immunotherapy based on several preclinical trials, phase 1 and 2 trials. It's been shown to disrupt tumor architecture and overcome immune exclusion, results in antigen shedding, and induces rapid disease control. Pembrolizumab plus standard neoadjuvant chemotherapy has actually shown great results recently in the Keynote 522 trial that showed the addition of immunotherapy increased pathologic complete responses by as much as 13%. Not to mention, though, the increase in some of the immunotherapy toxicity, which we'll come back to. Pembrolizumab was granted breakthrough therapy designation by US FDA in the neoadjuvant setting. And currently, we have another immunotherapy backbone that's been approved for first-line triple-negative as well. So how do these results of Keynote 355 fit in with other pivotal trials of immunotherapy in triple-negative breast cancer? In the neoadjuvant setting, Keynote 522, as I mentioned, this showed a benefit in all comers, regardless of PD-L1 expression, with a almost 14% improvement in path CR rate, which was statistically significant. In contrast, an additional trial called NeoTrip failed to show an increase in path CR with atezolizumab when added to nab-paclitaxel and carboplatin. And whether this was due to the chemotherapy whether this was due to the chemotherapy backbone or the immunotherapy alone is unknown. So in the metastatic setting, sorry, this is going a little nuts on me here. In the metastatic setting, in the first line, the Impassion trial used nab-paclitaxel with the backbone of atezolizumab and showed an increase in progression-free survival. And so this is somewhat a similar trial using a different chemotherapy backbone with pembrolizumab. In the second and third line setting, we've had no wins as far as immunotherapy. And I think that points towards the immunogenicity of triple-negative cancer in earlier lines of therapy. So this is the Keynote 355 study design. Eligibility criteria was relatively standard. You had to be clarified as triple-negative breast cancer and have PD-L1 expression. So whether or not you had PD-L1 expression was allowed, but they did stratify patients based on the amount of PD-L1 expression in both the tumor cells as well as the immune cells. So the backbone of chemotherapy was either a taxane-based or carboplatin and gemcitabine with the addition of pembrolizumab or placebo every 3 weeks. The average amount of immunotherapy was given for over 35 cycles, and Dr. Maimani had asked me earlier how much chemotherapy was given, and I really can't find that answer, but in the Impassion trial, it was approximately 22 weeks of the chemotherapy, which is on average just over 5 months. So baseline characteristics, also pretty standard across both arms. Patients were, again, stratified based on the amount of PD-L1 positive cells, but this was an intention to treat analysis, so all patients were included. This is the big slide that shows progression-free survival in the PD-L1 composite score greater than 10, which shows a very significant hazard ratio of 0.65, which basically means a 35% improvement in progression-free survival. This is very similar to the Impassion trial and atezolizumab, where we're seeing similar results. And again, gives us another signal that for first-line triple-negative breast cancer, immunotherapy does seem to benefit patients that have PD-L1 expression and increased immune cells at the site of the tumor. This is the intent to treat progression-free survival, and then although not statistically significant based on the pre-specified statistical analysis of the trial, it still shows that overall efficacy was demonstrated. So as far as unique side effects, we know that immunotherapy is not chemotherapy. The side effects we typically see as medical oncologists mostly include endocrine abnormalities. Anything such as an autoimmune disease can present with. Frequently, we're seeing hypothyroidism or hyperthyroidism, pneumonitis, colitis, and severe skin reactions. These are manageable, and you can see that only 3.9% of these side effects led to continuation of the drug. So in summary of Keynote 355, pembrolizumab plus chemotherapy resulted in a statistically significant and clinically meaningful improvement in PFS versus chemotherapy alone for first-line treatment of PD-L1 positive patients. A trend towards improved efficacy with PD-L1 was seen in the intent to treat population. Improvement of PFS was observed across all patient subgroups, and the safety was consistent with known toxicities of each regimen. These findings do suggest the role for the addition of pembrolizumab to standard chemotherapy for first-line treatment of triple-negative breast cancer, and I do think practice changing. The final trial I'll talk about today is the HER2CLIMB trial. This has been presented previously, and I'm really going to look at a subset of this trial looking at brain metastasis. So HER2CLIMB was a trial looking at a new novel agent called tucatinib versus placebo added to trastuzumab and capecitabine for patients with previously treated HER2-positive metastatic breast cancer with brain metastasis. So up to half of patients with HER2-positive metastatic breast cancer may develop brain metastasis, and effective and tolerable treatment options are needed. Tucatinib is an oral tyrosine kinase inhibitor recently approved by the FDA that is highly selective for kinase domain of HER2. It has minimal inhibition of EGFR, so it does have less toxicity than some of the previous oral agents, less skin rash, less diarrhea. The schema of HER2CLIMB trial is shown below. Again, these patients were HER2-positive metastatic breast cancer. They did have to have prior treatment with trastuzumab, pertuzumab, and T-DM1. ECOG performance status had to be very low, but this is mostly the case with trials, and a brain MRI at baseline. So they were randomized to a backbone of trastuzumab and capecitabine with or without tucatinib. So what do we know about previous trials for HER2 brain mets? Well, you can see that outcomes for patients with brain mets remain relatively poor, with progression-free survivals ranging from 2.5 to 5.5 months, and many times with no good local control in the brain. So in the previous analysis of HER2 CLIMB, which has already been published, all of the primary endpoints were met. So you can see by the 3 boxes here that progression-free survival was improved by 46%, overall survival improved by 34%, and then progression-free survival with patients in brain mets also improved a significant amount, up to 52%. So specifically in the patients that had analysis of this treatment effect with brain mets, you see that for these patients, brain MRI was required every 6 weeks for the first 24 weeks, and then 9 weeks thereafter. Eligible patients were those who did not require immediate local control to their CNS lesions, but if such lesions were discovered at screening on MRI, a patient could elect to receive local therapy at that time. Patients were followed then for progression. These are the baseline characteristics of patients enrolled, which we discovered that were very similar on both arms. Non-CNS metastatic disease was present in most. Prior radiotherapy was either whole brain or targeted therapy. Surgery was also allowed. So the big slide here, well, almost the big slide, this is the PFS slide. The overall survival slide is also very impressive, but this shows a significant benefit out at 1 year, 40% of patients being alive with the addition of tucatinib with underlying CNS metastasis versus 0% of patients being alive at that 1 year mark. Overall survival benefit also statistically significant with pretty wide separation of the curves going out past 12 months. So this I found extremely interesting. This trial did allow isolated progression in the brain with continued assigned study treatment. So you can see at the first CNS local progression, patients could stop treatment, have local therapy at that time, and then continue on tucatinib. And what you see is that on second progression, tucatinib is still very effective with a 7.6-month median time to progression or death versus 3.1 months. So this is still showing we see a lot of CNS penetration with this drug beyond progression. That is very impressive. So as far as conclusions for HER2 CLIMB, the addition of tucatinib to trastuzumab and capecitabine doubled the intracranial response rates, reduced the risk of CNS progression or death by 2/3, and reduced the risk of death by nearly half. The CNS progression-free survival results represent a delay in prognosis in the brain. Tucatinib is the first TKI to demonstrate prolongation of overall survival in patients with HER2-positive metastatic breast cancer with brain metastasis in a randomized controlled trial. These results, together with HER2 CLIMB primary analysis, demonstrate that this is an active regimen for intracranial and extracranial disease in patients with HER2-positive metastatic breast cancer. So my summary of all 3 trials is presented here. ECOG-2-108, we now know, I think, pretty conclusive evidence that removal of primary breast cancer does not impact overall survival. There's no impact on quality of life. There certainly is a role in palliation and possibly in illegal metastatic breast cancer, but ongoing trials are opening to address this question. For Keynote 355, we finally have seen benefit in immunotherapy in breast cancer now for 2 trials. Definitely have to consider the backbone and unique side effects. In the neoadjuvant setting, it's a little more questionable with the additional side effects, but also something to have extensive patient discussion. Finally, in HER2 CLIMB, tucatinib offers a great option for the brain metastatic population. Interesting thoughts would be preventative trials with these drugs, so prior to a patient even having brain metastasis, and then the unique population of leptomeningeal disease, which is frequently omitted from clinical trials. So that is the conclusion of my brief summary of those 3 trials, and I thank you very much for listening. So let's see if we have any questions ongoing here.
That was an amazing talk, by the way, Sarah. I don't think we have.
Not so far.
Oh, there you go. I don't think we have any questions thus far.
Would you explain what LRT and systemic therapy entail? Great question. So LRT stands for local regional therapy. So when a woman is diagnosed with breast cancer, the primary most of the time is in the breast, and then metastatic disease would be outside the breast, involving bone, liver, lungs. So that trial, ECOG 2108, was designed to see whether or not we should be addressing the breast at all when the breast cancer has already metastasized and moved on to an incurable setting. So the answer to that question now, I believe, is no, unless palliation is needed for pain control, skin irritation, or bleeding.
So I have a question for you, Sarah. Can you hear me?
Throw those questions out if you have them.
Sarah, can you hear me now?
Okay, so I've got one question for the oligometastatic disease, metastatic breast cancer. Did the 4-site threshold mean 4 different organs? Or what about if you potentially have multiple mets within one organ? Yeah, so the answer to that is just 4 sites, whether it's 4 bone sites, 1 in liver, 1 in lung, 1 in bone, just 4 total and not more than that. And so those are questions that we have yet to answer. I think if someone is fit enough, at this point, I would try anything to deal with a minimal amount of disease so that we're rendering a patient no evidence of disease on scans. You know, I think it helps a lot of things without knowing a survival benefit right now, and I think I would take that leap, but we don't know definitive answers yet. Let's see, I've got another one here. What are some of the side effects of immunotherapy? So immunotherapy is very different than cytotoxic chemotherapy. There we have to worry about really lowering the immune system, affecting white blood cells, red blood cells. I think patients are very familiar with nausea and hair loss and the effects it has on liver and kidneys. Immunotherapy is the ramping up of a T cell population. T cells we all have present in our body. The overstimulation of T cells is commonly what causes autoimmune diseases, so things like lupus or rheumatoid arthritis. When we do this in the cancer setting, the T cells can flare up and cause similar side effects, such as autoimmune disease, but sometimes not always exactly the same. So we can see autoimmune thyroiditis, either hypo or hyperthyroidism resulting in that. We can see the pituitary gland actually taking a hit and causing multiple endocrine abnormalities. We can see a flare up in the colon, such as colitis with severe diarrhea. Sometimes we see generalized musculoskeletal pain that's not easy to pinpoint. Rashes and fevers are also possibilities. So those are the most common things we see, as well as pneumonitis. I forgot about that, which is an inflammation of the lining of the lungs. Many of these things can be treated with steroids, but the hard part as a medical oncologist is balancing side effects and giving the steroids, because the steroids can sometimes abate the effects that we're wanting to see from immunotherapy. And I think that's most been demonstrated in lung cancer, not so much in breast cancer at this point. I'll give you guys a few more minutes for questions. Thank you for being patient. This is my first time to do this live, and it's a little nerve-wracking because I'm technically okay, but sometimes I feel like it's way beyond me. So I appreciate that. Sorry about the slides rolling around a little bit. Are there, let's see, we've got a question. Are there any other upcoming trials? Okay, great. Lots of trials. In USON currently for immunotherapy, because we've got 2 randomized controlled trials showing the benefit of immunotherapy, I don't know that that's going to be repeated, maybe in further line settings, although we're not really getting a signal that that's beneficial. The space now that we're looking at is the neoadjuvant space. That means before surgery, whether or not adding immunotherapy to chemotherapy really improves response rates and portends for an overall survival benefit. I think we've got some suggestion of that with Keynote 522 that use pembrolizumab in conjunction with paclitaxel, carboplatin. But I think, I think there's kind of a debate as far as oncologists go right now, just because we haven't had long-term results or we haven't seen that play out into overall survival benefit. So some of us that want to treat stage 2 or 3 very aggressively will certainly start out with that. I am trying to be involved in a trial that's using immunotherapy in a locally advanced hormone positive breast cancer, but that has yet to open. As far as HER2 and tucatinib, we have tucatinib for use ongoing right now, as well as other HER2-directed therapies. We do have a tucatinib trial in Denver as well, but I think that it's really going to be fast-tracked and readily available for all of us at this point. We've got some metastatic hormone-positive trials coming down the pipeline, 2 of which are open here currently, looking at more endocrine avenues to block resistance that I'm a part of. Let's see. Any other questions? I think I answered all of those. Anything else? Dr. Maimani?
Can you hear me now? No, still can't hear me. Oh. Technical difficulties. Funny thing is she's literally right next door to me. So.
Okay, well, if you need to reschedule or change anything.
Well, I'll just say before I wrap up that, as you can see by at least 2 of the presentations looking at triple negative breast cancer and HER2 or HER2 positive breast cancer, therapy is definitely different across subtypes. So it's very important to talk about that with your medical oncologist and how therapy can be tailored best for the patient, because it's no longer a one-size-fits-all. I compliment both the ECOG 2108 trial, because it was a negative trial but still gave us great answers to questions patients ask me every day. And I compliment the HER2 CLIMB trial because it enrolled patients that we usually don't enroll. So typically trials will not want to enroll patients that have barriers at the beginning. So in other words, if they have CNS metastasis, brain metastasis, in a typical situation, they're more likely to do poorly. And so then a lot of trials won't allow patients to be admitted to the trial. It's an exclusion criteria, but now we're seeing a liberalization of clinical trials, and hopefully we see that in more of the elderly population and patients that have symptoms or presentations that we're not used to and uncomfortable with. I think clinical trials are very important for these reasons.
audience. Her name is Dr. Robinson. How are you? Hi.
Okay, guys, I'll give it one more minute, and then if no more questions, we'll sign off. And maybe I'll do another one at some point. Just let us know some feedback of types of things you want to hear about.
So that starts it. Oh.
Okay, thank you all very much. Have a wonderful day. Stay safe, stay healthy.